Hi, everyone. Welcome to today's webinar. My name is Chad Sievers, and I'll be the moderator today. Today's topic is about medical trauma, and I'll have our speaker introduce herself here in just a bit. But I know it's been a topic we've been trying to get on the books for a while, so I'm glad we're going to be talking about it today. For those of you who are not familiar with our program, I just want to do some brief introductions about who we are. Arkansas Building Effective Services for Trauma, or ARBEST. We are a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children who have experienced trauma from events such as abuse, natural disasters, and even family separation. We work really closely with our state child advocacy centers and other providers here in Arkansas to build a trauma-informed mental health system. And we're probably best known for providing trainings to mental health professionals and treatments that are effective with helping children recover from trauma. And so I'm going to just do a couple of housekeeping announcements for folks. We really encourage you to ask questions during the presentation. In fact, we'll even probably prompt you to type in a few questions or comments. And to do that, you can use the question feature that's on the right side of your screen. If you are interested in earning a CEU, just be sure to stick around to the very end. I'll have a code that's given, and I'll go over some more instructions when we get to that point. But if you're interested in a CEU, just stick around to the very end. We are recording this webinar, and we'll upload this presentation to our YouTube channel. And if this is a topic or you like these kind of trainings or CEU opportunities, check us out on Facebook. We frequently post training opportunities there. And I am going to let Dr. McBain kind of introduce herself and take over the presentation here.
Hi, welcome everyone. I'm so happy to be here and talking about this topic that is very near and dear to my heart. We are, of course, going to be talking about a topic related to trauma, which, of course, can bring up feelings for people. And so if you find that you need to take a break or some of the content feels a little bit much for you, please give yourself that grace to take that break if you need it. We're not going to go into anything too in-depth, so I don't have any trigger warnings or anything like that, but just know that you can give yourself that permission. So I'm Dr. Sacha McBain. I'm a clinical psychologist by training and associate director of the Center for Trauma Prevention, Recovery, and Innovation here at UAMS. I'm also an assistant professor in the departments of psychiatry and surgery. So I spend most of my time working with our trauma team in our inpatient trauma surgery service, providing early intervention to those on the service. And then I also do some outpatient PTSD work in Walker Family Clinic with adults. So I am an adult psychologist. I did my best to kind of focus this across the lifespan, but I'll ask that you give me a little bit of grace when talking about child and adolescent focused issues. I'll do my best to kind of answer those questions. So I've worked in lots of different clinical settings where medical trauma might come up, including places like acute rehab. I've worked in a pediatric emergency department, ICU, and with a rehab team, palliative care and hospice care, general consultation liaison work, family and internal medicine on a burn unit. And then, as I mentioned, I now work in trauma surgery in an ICU and then do some outpatient specialty mental health work as well. So I have lots of different experiences, and we're going to keep this a little bit more broad. So I hope this will kind of pique your interest on this topic and that you'll kind of do some more exploring and research on issues that might be most relevant to the patients and clients that you might be working with. So the objectives for today is first, I want to spend a lot of time actually providing a conceptual overview of medical trauma and traumatic stress related to medical events. And then at the end, or about halfway through the presentation, I want to introduce some supplements to trauma-focused treatment that meet the unique biopsychosocial needs of those with medical traumatic stress. So I'm kind of making the assumption that those of you on the call know how to work with trauma more generally, and that you're here for a little bit more of a specialty, in-depth look of a particular type of traumatic experience. I wanted to start with this quote by J.H. Vandenberg in his 1972 book, The Psychology of the Sickbed. And it says, "The body is a healthy person's faithful ally. The healthy person is allowed to be their body, and they make use of this right eagerly. They are their body. Illness disturbs this assimilation. Our body becomes foreign to us. The body has become unfaithful. The trusted ally has become an antagonist, a fierce enemy. The sick person has to revolt against it." And I remember that when I first read this, it not only resonated for me personally, but it really motivated the work that I wanted to do in my career and in the research that I do, because I don't think that this has to be the case when we experience medical trauma. And part of the work that we're doing when we're treating medical trauma is trying to reintegrate the mind and the body. So I want to take a moment for you to think about a time in your life where you have a place that you know, whether it was your childhood home or a favorite hangout when you were younger, and you went away from that place and you held these memories of it. And for some reason or the other, you went back to that place. And everything felt just a little different, like everything felt just a little off kilter. You know, you think about that childhood bedroom where everything seems a little bit smaller. The bed seems a little bit narrower than you remember it. The ceilings are a little bit lower. And that's sometimes what can happen with this experience of medical trauma, is this body that we think that we know so well, that we have so many memories attached to, is when something fractures that relationship, it leaves us feeling a little bit foreign to that space and to that space of our body. And again, what we're trying to do is to refamiliarize ourselves and reconnect with the body after this fracture of medical trauma. So this is a quote from 1972, but this is a conversation that's been continuing to happen. And I've seen a lot of things come up on Instagram lately around some of these concepts, which I think is actually pretty cool. So the first one in the lime green is kind of what Vandenberg is saying, you know, that navigating a body that feels like betrayal is really difficult. But there's also been some changes in thinking when we think about medical trauma, that's not just this us versus our body, but how our relationship with ourselves, but also within the context of our community and our society, and the things that the messages that we internalize also impact our relationship with our body. And so you can kind of see in this middle meme, and we don't need to kind of read the details, but basically that sometimes our relationship with our body is not only fractured by things that are happening within it, but also by things like internalized oppression or internalized ableism, or this idea of the way that capitalism informs that we're good members of society only when we're able to contribute to work. And if our body function changes and we can't contribute that same way, what does that mean about us? There's also, in some cases, where people are very attuned to their body. And so Serena Williams talked about this experience when she had to have an emergency C-section, where she very much knew what the signals of her body were telling her, and she was very attuned and connected. But because of the system of care that she was in, where there's this experience of systemic racism and medical racism in this context that she was in, that there was this forced separation or this inability to act on that intuition because of the system of care that she was in. And so for those of you who can't read this text, basically she knew and she recognized this feeling in her body that she was having a blood clot, but she wasn't listened to. And so then that caused all these other significant problems for her that then resulted in this medical trauma. So if we kind of think about how do we define medical trauma, there's a couple of definitions that kind of come up in the literature. The first is from the pediatric medical traumatic stress literature. And it says that medical trauma is a set of psychological and physiological responses to pain, injury, serious illness, medical procedures, and frightening treatment experiences. The second is by Edmondson, and he talks about medical trauma, and a lot of his work is in the context of cardiac events. He talks about this as an acute onset of a disrupted physiological system in which the ongoing threat is internal, it's within the body. So he calls it this enduring somatic threat. And it may be long-term or even permanent. And so when we're thinking about what we think about generally about a traumatic experience versus a medical trauma, there's this physiological component of it, both in terms of the experience itself, but also how that physiological response continues to perpetuate reminders or threat of the trauma. We also know that medical trauma is not just, again, that mind-body connection or that physiological piece, but it also happens within the context of the system of care itself. And medical trauma can be enacted or even reenacted within that system. And it's often intertwined with isms, racism, ableism, sexism, and discrimination, fat phobia, or moralizing of health, and that sick people aren't doing the right things, or if they tried a little bit harder, or if they did XYZs, they wouldn't be experiencing these problems. And this is also a perpetuation of power differentials in the healthcare system, where patients leave feeling disempowered and marginalized. Oftentimes when we're thinking about medical trauma, the things that come up over and over again is I wasn't listened to. I wasn't given the information that I needed. I didn't know how to navigate this system. Or this deference to medical providers as these kind of all-knowing figures, and then feeling let down by that kind of idealized version of what a provider is and what they can offer us. So this is all to say that when we're thinking about medical trauma, there's this change to the body. The body's integrity is compromised, and the patient has a psychophysiological response to it. And that is experienced interpersonally. So there's the intrapersonal experience and there's the interpersonal experience that is perpetuated by providers or family members or a community or how a society views somebody who has disability or illness. And then there's the existential or spiritual experience, often related to mortality, that accompanies medical trauma. Medical trauma can result in lots of different types of crises. So we can think about the physical crisis, that physiological component, the emotional piece that we've talked about. It can also have an impact on our relationships, our sense of identity, who we are if we're not able to do the things that we wanted, or if our body is in the condition that it's in. Invisible disability and what that means about us, and if we really belong to, a disability community. It can have an impact on our development. And this is across the lifespan, but especially relevant for our kids and teens who are experiencing medical trauma, where due to hospitalizations or treatment or restrictions may miss developmental milestones. I think that we can all think about with COVID and these kind of strict quarantine procedures that we've been in, that's the reality for some people, regardless of if there's a pandemic or not. And that isolation and that quarantine that can come with some experiences of illness can be extremely traumatizing and lead to missing of developmental milestones or relationship building. Medical trauma can also impact our experience of pleasure and hobbies. If somebody is in an accident and has chronic pain and their favorite thing to do was go running and they can't do that anymore, there's a crisis there of pleasure and hobby and enjoyment. And then of course, this kind of overlaying existential crisis that can come with all of these components. It's important to note that when I'm talking about medical trauma, I'm talking about a type of trauma exposure, not a diagnosis. Medical trauma can lead to post-traumatic stress disorder, but it's not the only outcome. People can experience depression, anxiety, OCD, et cetera, related to medical trauma. And really, we want to break it down into these different components. Most people will be exposed to something traumatic in their lifetime. And most people will have some reaction to that, including cognitive, emotional, social, physiological responses that really vary in intensity. And most people will go on to recover naturally over weeks, months, or even potentially years. For those who do not recover naturally, for reasons that we'll talk about in a minute, they can go on to develop things like acute stress disorder, adjustment disorder, PTSD, depression, anxiety. So I'm talking to you about an experience that is potentially traumatic, but may not necessarily always lead to PTSD. When we think about medical trauma, we can think about it in these different levels. And so we can see here that we have to think about the potential threat to life and also the potential psychological or emotional distress that accompanies the traumatic event. And so when we think about medical trauma, we can think about what was called level 1, these planned or routine medical procedures. Going in for a pap smear can be traumatic for some people based on their previous existing experiences. The potential threat to life is probably low, but the emotional distress can still be high. And then there's level 2, these life-threatening or life-altering diagnoses. So this is when we're starting to think about chronic illness or kind of catastrophic diagnoses. And then there's level 3, which are these medical emergencies. So this is kind of where I live and work, is with this acute care. And so you can see here this kind of diagonal line that when the threat to life is potentially lower and the emotional distress is a little bit lower, we can focus on prevention and wellness. But when the higher the threat to life and the higher the level of emotional distress, that's when we're starting to think about more traditional mental health intervention. And we'll talk about both of these components. This is just a snapshot of prevalence of PTSD by index trauma or by specialty. I'm talking about medical trauma in a big umbrella way, but there's literature and relevant intervention and based on different presenting problems. So I'm staying broad-based here in this talk, but there's a lot more to learn when you kind of dig into these different pieces of experience. So as an example, like with the population that I work with traumatic injury, about 30% of people who are hospitalized following an injury will develop PTSD. I want to draw your attention to inflammatory bowel disease, and I purposely put here post-traumatic stress symptoms because many of the experiences that people identify as traumatic when it comes to IBD and the surgeries and the restrictions that are involved with that might not necessarily meet criterion A for PTSD, but they can absolutely still be experienced as traumatic and look like post-traumatic stress symptoms. And you can still treat it using what the interventions that we know work for PTSD, even when you're not necessarily meeting criteria for that diagnosis. And then this R&R here is this kind of resistance or resilience. Some people never have any reactions, and that's called resistance. Some people will have those normal reactions that we talked about and then go on to recover, and that's called resilience. When it comes to pediatric cancer, I think that this is an interesting one because children who experience pediatric cancer, about 20.5% of children will experience PTSD related to their own cancer diagnosis. Parents have a little bit higher rate of PTSD. It's around 25%. And siblings can also experience PTSD related to their siblings' cancer experience. So when we're thinking about medical traumatic stress for children, we're not just talking about the child, we're also talking about their caregivers or their siblings or their family system. Again, for the purposes of this talk, I'm going to be talking more about the individual's experience, but just know that this also applies to those around the person directly experiencing the trauma. So you might be asking, and other people have asked, why do some people recover naturally and some go on to experience PTSD or have these other negative health outcomes? And so, of course, there's been a lot of literature and research into what are the risk factors? What gets somebody off the course from natural recovery? For adults, there's a lot of pre-trauma risk factors that have been identified in the literature, and they're common things that we see with lots of other types of mental health concerns. Gender identity, especially if somebody identifies as female or as a woman. Minority status, either when it comes to race, ethnicity, or sexual or gender minority. Limited education, low SES, adverse childhood experiences or prior trauma, pre-existing psychopathology, and life stress. I think when we're thinking about these pre-trauma risk factors, I don't necessarily think that this is because of any necessarily biological vulnerabilities. That might be part of the picture. But I think that if we think about, again, the conceptualization of medical trauma being within the context of care and the context of experience, it makes sense when we think about components of discrimination and mistreatment and invalidation and how that overlays with some of these demographic factors that are at most risk. There's also peri-trauma, or things that are happening during the trauma that put somebody at greater risk to experience later PTSD, including perceived life threat, as we saw in that figure from earlier, the trauma type. So when it comes to traumatic injury, an intentional injury, so the person knows that this was done to them on purpose, puts them at a greater risk. But we can think about the life threat and the procedures involved, et cetera, that can sometimes be related to trauma type. And then those interactions with medical staff or environment. After the trauma, if somebody is experiencing acute distress or symptoms, so the greater the symptoms are initially, the greater likelihood that somebody will go on to maintain those symptoms over time, and then at that 1 month mark meet PTSD criteria. Social support or social constraints, so a lack of social support or the presence of something called social constraints, which is where people intentionally or unintentionally are trying to minimize disclosure and processing of the traumatic event. You can think about this in terms of like a traumatic labor and delivery. Oh, you survived, your baby's okay, why are you worried about that? That's a social constraint. It might be said in the best of intention of like, be grateful that you and your baby are here, but it can really minimize disclosure in a way that can contribute to the development of PTSD symptoms. Life stress again. So I often see, when people are in the hospital and they know that life is going on without them outside of the hospital. They still have bills to pay. They still have all the other things that were stressing them out before they came in. And on top of that, now they have all this new stress associated with their injury or illness or diagnosis. And then uncontrolled postoperative pain. There's been literature to show that uncontrolled pain is a greater risk factor for later PTSD for adults. These risk factors look similar for children. We don't have as many of the demographic factors listed here, but I would venture to guess that they also apply for children. Younger age, of course, that makes sense in terms of how children are able to understand their experiences and make sense of what's happened to them. Previous trauma experiences, a history of behavioral or emotional problems, peri-trauma, physiological arousal, So when children have earlier elevated heart rate during an event or closely following, they're more likely to have PTSD. Of course, the exposure to scary sights or sounds during the hospitalization, separation from parents or caregivers, the length of hospitalization, which of course, the longer you're in the hospital, the more likely you are to be exposed to these other things, the number of procedures, and again, those interactions with medical staff and the environment. In the post-trauma phase, the same thing for children, and I think this lack of peer support is an important factor, also in terms of representation, seeing other children who have the same experience, or going back to school and being the only kid who was hospitalized for a month, can be really alienating and difficult for children. For adolescents, I think that there's an overlay of both adult and child risk factors. And it just really emphasizes that medical trauma needs to be conceptualized through a developmental lens, and how these potentially remote history of medical trauma might interact with the life stage. And so teens who survive pediatric cancer actually have higher rates of post-traumatic stress symptoms than child survivors do. And I think part of that is as children grow up and they become teenagers and adolescents, and young adults, they understand their experience a little bit differently, which can then lead to these reactions. Or they come up against new difficulties and milestones, and they feel different from other kids, and that can lead to difficulty with adjustment. This is just a reminder of the PTSD criteria. Medical trauma, PTSD related to medical events, is the same in terms of diagnosis, but there are some things that the distress can look a little bit different. So for adults, medically undiagnosed symptoms. So when people are going in and they're just not getting the answers, and there's these components of their experience that it's just, there isn't anything that anyone can objectively pinpoint. That's sometimes a sign for me that there's some medical trauma happening, or this can be possible with other types of trauma as well. I want to be careful with that one though, because sometimes when people learn about how the impact of trauma can look like these symptoms, it's easy to then say, oh, it's because of your trauma or your anxiety. So I'm not advocating for that either. There has to be this kind of mix of understanding that sometimes it is a psychological component, and sometimes it's really, we just haven't discovered what's going on. Complex co-occurring chronic health problems. Ambivalent or insistent engagement in care. So for some people, as we would expect with PTSD, there's complete avoidance of the care environment. They don't want to go back, they don't want to be reminded of it, they don't want to be in an environment with those same sights, smells, sounds, etc. Other people do the opposite, or sometimes have a hybrid of this, where there's high utilization of care or an inappropriate level of care. So I worked with a patient in family medicine who had an acute coronary event, and anytime he felt any shortness of breath or a heart palpitation, would go to the emergency department. And of course, when he got there, he was always told that nothing was wrong with him, and it was a really invalidating experience for him, and it would start the cycle over again. And so that is what this kind of distress over his heart condition, was trying to self-soothe and regulate by getting reassurance from a system that wasn't really prepared or able to reassure him in the way that he needed it. We can also see inconsistent treatment adherence or disengagement from self-care. This is the people that I see that have a list of 20 medications and they take maybe one of them. And when you start to dig in of why they're not taking it, it's a reminder that I have to deal with this. If I take my insulin, then I have to step away from my grandkids, and I don't want them to know that I'm sick. It can be lots of different things. Disruption in interactions within the context of care, difficulty trusting, being on edge with providers, being reactive, can be all signs of distress related to medical trauma. And then, of course, like with any type of trauma or PTSD, distress when confronted with things that remind somebody of the event. And even reminders of a reminder. Again, similar with children, but thinking about it through their developmental lens. In terms of medically undiagnosed symptoms for children, this can often look like belly aches or headaches. We can see more readmissions or complications. This can also cue to me that the family unit is having difficulty. That a parent might be having some symptoms or avoidance, and it's making it hard to support their child's care, and that can sometimes lead to readmissions or complications in the child's care. Avoidance of care environments, I imagine that this might look similar to what school refusal might look like for kids. Of course, changes in academic functioning, behavioral outbursts or stonewalling, separation anxiety. I think for teens especially, there can be this sense of foreboding doom. I think about the kiddos that I used to work with cystic fibrosis. And as the research is growing about, survivorship of CF, a lot of these kids and their parents, when they were first diagnosed, were told that they might not live into adulthood. So the closer that they creep into their late teens and 20s, the more that they feel like they're living on borrowed time. This is also true in terms of like thinking about kids who, go to diabetes summer camp, and they come back the next summer and they find out that their best friend, their bunkmate from last year, died due to complications, or had to get a transplant, or et cetera, et cetera. And there can be this sense of, am I next? Is this going to happen to me too? And then, of course, with teens, we see the normal risk-taking behaviors, but there can be an extra layer of lethality or risk for kids who are in some way, immunocompromised or have these other concerns that can really, we can see a lot of boundary pushing when it comes to treatment adherence, which can be much more risky for kids who have medical trauma or are dealing with illness or injury. Of course, we have to talk about COVID when we're talking about medical trauma. In a recent study, 55% of patients treated for COVID-19 at home or in the hospital met criteria for at least one mental health diagnosis. 28% met criteria for PTSD, and 40% met criteria for insomnia. I think at this point, we have to recognize that mental health concerns will be a part of COVID-19 survivorship, especially for those who required ICU admission. And as we learn more and more about COVID long haulers, there's been this really kind of cool partnership and collaboration with the chronic fatigue community about what that looks like and how to adjust to these kind of unrecognized, seemingly untreatable symptoms that are coming for long haul COVID, people with long haul COVID. There's already been a lot of literature about PTSD in the ICU setting. So even before COVID, this was something that was really prevalent in the literature. And we know that about 1 in 4 ICU patients develop PTSD after admission. Anxiety and depression are also really common in this population. And there's a lot of reasons why that might be. First, these are patients who are critically unwell. And so we can think about that there are some biological or physiological components that might put somebody at greater risk for anxiety, depression, PTSD. But also we can think about it through this more psychological lens of medical trauma. If you haven't ever been in an ICU or know somebody who has, it's an extremely difficult environment. There's a lot, people are in a lot of pain, even when we're doing our best to control it. The lights are constantly on. There's always beeping. There's noise. At UAMS, we have a closed ICU, so we have private rooms, but in other ICUs that I've been in, they look exactly like this. So if the person next to you starts coding and you're hearing all their alarms going off and they're crashing, and you're laying next to that, that can be obviously incredibly traumatic. Sleep disturbances, invasive procedures, partial consciousness due to high levels of medications, reduced ability to communicate. So if you're on a trach and you can't breathe on your own, or you can't communicate on your own, but you're aware. Another thing that often happens, and about 80% of ICU patients experience delirium-related hallucinations, and have this pretty significant memory fragmentation of their time in the ICU. And these hallucinations can be incredibly realistic and are often threatening. A lot of times people will have hallucinations that their care team is trying to kill them when they're trying to provide care, or that they're seeing scary things. So it can feel extremely real. The unique parts of a medical trauma memory, I think, is that there can be this almost like perspective memory, right? Like, so this moment of learning bad news, of getting a hard diagnosis, and then that, you do this kind of flash forward of, oh my gosh, okay, I just have been diagnosed with stage 4 cancer. This is what it's going to look like, and I'm gonna die, and I'm gonna suffer, and all these things are going to happen. And people live those flash forwards as if they've already happened and as if they're memories. We can still target them in the same way that we do with any type of cognitive therapy, but they're things that haven't happened yet, but have still maybe been installed as if it is a memory. And then, of course, those hallucinations. And people often fear that because I was delirious or I had hallucinations in the ICU, does that mean that I now have a psychotic disorder, or that I'm going to have these hallucinations for the rest of my life? The answer is no, but we need to provide that psychoeducation and help people understand why they experience delirium in the first place. So what do we do to address this? How do we address medical trauma? I think that it's important that we think about it on a continuum of care, and that we think about this aspect of prevention and wellness. How do we stop exposure to medical trauma in the first place? This is a trauma where we do know where it's happening, and therefore we might be able to do something to at least in part stop some of the exposure. And we can address some of these modifiable risk factors that I've talked about, or mitigate the impact of medical trauma exposure. We can also think about early intervention. And so this is what the work that I do in the acute care setting is, how do we identify those experiencing distress early and provide them with the appropriate treatment? And then for most of you, it might actually be in this third phase of, what does treatment look like in the outpatient setting? How do we assess for symptoms or impairment related to a medical trauma and then tailor that treatment appropriately? So when we think about prevention of medical trauma, we can first think about primary prevention. How do we completely stop the exposure? We can focus on developing programs and policies that stop people from getting hurt or getting sick. If we can't do that, or while we're working on changing the world, we can address these modifiable risk factors. How do we address the medical staff and the environmental factors that contribute to this traumatization? How do we implement anti-racist trauma-informed care practices in order to address those modifiable risk factors? And when we can't do that, or as we're working on that, how do we mitigate the impact? Ultimately, there are going to be people who are exposed. And so what do we do to mitigate the potential impact of that event? And we can provide information on natural recovery and how to cope soon after exposure. And we can utilize integrated care to ensure that early support. And then we can think about, how do we highlight wellness? How do we utilize whole health or integrative approaches to care? This is something that the VA has been working on, and a lot of different healthcare settings have been thinking more about integrative approaches to care, and kind of how do we move away from a focus on sickness to a focus on wellness? And then how do we adapt our concepts of health? I talked about that sometimes what's leading to medical trauma, or some of the crises that I described, is internalized ideas about what it means to be quote unquote useful, if I can't do this thing, or internalized ableism that can come up when people experience medical trauma. And so how do we reconceptualize our relationship to health and our bodies in a way that's centering patients' intersecting identities and values? When we think about early intervention for medical trauma, we want to first identify who's experiencing distress. If we know that those who are having high early distress are the most likely to develop PTSD, then we want to identify them first. And so that can be screening procedures in high-risk areas, integrating care with people who have expertise in a population and those unique aspects of care. So this is thinking about having mental health providers built into OBGYN offices, or psycho-oncology is a huge thing where psychologists are part of these oncology teams because they know that this is a high-risk population and that there's those unique aspects of care. There's also been a lot more research happening around technology and self-help tools and websites that are focused on early intervention. And then how do we train people in the environment to provide support and care? Not all patients will want or be able to access mental health care. So how do we, instead of waiting for them to come to us, how do we equip those who are interacting most with this population to engage in interventions or strategies that will support early intervention and wellness? And then when it comes to treatment, we can think about how we're conceptualizing these patients and integrating these unique aspects of their experience. Trauma work, or at least within psychology, trauma psychology can be very siloed from things like health psychology or rehab psychology, and we don't have a lot of crossover in knowledge. So how can we integrate these principles, integrate health and rehab principles who do all this work every day, but don't necessarily have that PTSD experience? How do we bring in what they do into our trauma-focused treatment? Making sure that we're reading up on diagnoses and related components of care, and then making sure that we're collaborating and coordinating with our clients' treatment teams where possible. At UAMS, that's pretty easy to do. I can just send a message in Epic, but I've also been able to do that with people who have providers outside of our institution by doing a release of information and getting consent to be able to communicate with those care providers. And then consulting with other professionals who have expertise in your client's illness or injury. I want to go into a little bit more detail about some of these treatment aspects. And I want to encourage you to think about these types of patients through this biopsychosocial, and I've added spiritual case conceptualization. So this is where I'm going to ask people to, maybe if they're willing, to participate in the chat and tell me, what do you think might be some of the predisposing factors that would increase the risk for a problem or increase the risk of having medical traumatic stress? And so this might be where we think about those pre-trauma risk factors that I've talked about. What comes to mind for people about what might be a factor here?
Yeah, so you can type into the question feature and I can read those off. So somebody said ACEs, adverse childhood events,
Yes.
childhood trauma, not having a support system, social support.
Yep. Yeah, exactly. So anything, like any of those pre-trauma risk factors that I talked about, like those demographics, age, race, ethnicity, sexual or gender minority status, that life stress. Sometimes if somebody has a family history of disease, so I've worked with patients before where, they saw their parent have a stroke, and then they are now, really worried or preoccupied if they have a stroke, even if the severity is very different, because they've seen what it looks like up close and personal, and so that can sometimes increase the fear or risk around what their experience might be. Great, thank you. The second is these precipitating factors. These are stressors or events that cause or contribute to the symptoms or distress. Any thoughts from the group about what some precipitating factors might be.
Financial limitations.
Yep.
Racism.
Mm-hmm.
A lot of them in here. Lack of access, no insurance, access to care.
Yep.
Chronic homelessness.
Yep, absolutely. So those, I think, those things that people have mentioned, I think are spot on for precipitating and also perpetuating. So they can be precipitating in terms of the biases that come along with engagement in care. You know, I think that I often see that where it's like, oh, this person, you know, didn't take care of XYZ, but it's like, well, they didn't have the resources to be able to do that, right? And so that then influences how the team is making sense of them and how what they're willing to do to support that person intentionally or you know, in their awareness or not. But then, of course, oh, go ahead.
I would say there's another interesting comment here that I just want to mention: increased appointments that lead to potential loss of job.
Yes. Yeah, that's a great one. That's so true. That this is, you know, I've talked a lot about the healthcare system, but we also can think about like the systems of work too. And that's I think that is a huge one, especially when somebody has kind of chronic health problems and how that rubs up against their work environment. And actually just had somebody the other day who really needs to go into acute rehab, but he's like, I can't afford the time of 2 weeks in a rehab. I'm going to lose my business.
Yeah.
And so that's a real conflict and stress between, can I afford to potentially go to rehab, which I know will maybe potentially benefit me more long-term in terms of my health, but could cost me my business. You know, these are the real stressors that come up with medical trauma that, you know, if we're looking at this figure again, is all of these things and impacts every little piece of our lives. Thank you all for that. And then the perpetuating factors, you know, these are things that are just kind of exacerbating the problem. So these are things like those, like life stress that people mentioned, homelessness, job components, living environment, financial stressors, some of these crises that we've talked about. I think something that's incredibly relevant and on my mind right now is policies and legislation. So when we think about, you know, these trans healthcare bans that have just happened in our state, that's extremely traumatic for people who need access to that care. Any other thoughts on perpetuating factors that I haven't mentioned?
If a criminal or civil case, court.
Yes. Yeah, great one. Okay. I'm just being mindful of time, so I'm going to move ahead. But I think that with protective factors too, we can think about, you know, social support, having a trusting relationship with your provider, even if it's you know, or if it's not the one who was maybe involved in the medical trauma, but, you know, later providers, or these communications and interactions, the education that somebody gets, financial security, you know, access to child care, job stability, time off, health insurance, life insurance policies, health literacy is a big one. Somebody knowing how to navigate a healthcare system, know how to access resources, know how to fill out a disability form are all things that can be protective, but also conversely perpetuating for those who don't have access to those things. This is just to kind of visualize, you know, a lot of what we've been talking about is thinking about privilege and oppression. And I think when we think about privilege, it's not thinking so much about like where we have the leg up necessarily, but sometimes we can think about it as the reverse of what absence of barriers do we have? What things don't you have to deal with? That things that don't make it more difficult for you to navigate. And thinking about that in the context of your patient's medical trauma, right? Being able to navigating a healthcare system as a disabled, queer, Black woman is different than for somebody else, and really thinking about and conceptualizing that when you're thinking about medical trauma and the person's experience with their treatment team or with the system more broadly. Integration of health and rehab psychology principles. So I'm not going to go into in depth of each of these, but this is just to give you some ideas. It is indicated to use the standard evidence-based PTSD treatments when addressing PTSD related to medical trauma. And so, as I mentioned earlier, it's like even if somebody's not meeting criteria for PTSD, we can still use components of cognitive therapy, or we can still use exposure, or, we can still do these things to help somebody overcome a medical trauma, even if they don't have PTSD. Some of the things that I think are really important to integrate from health and rehab psychology, and I encourage you to investigate some of these other skills if you're working with people who have medical trauma, is first getting really aware of like how to provide psychoeducation and normalization. So like I talked about delirium before, or thinking about the relationship between stress and diabetes and how stress is related to blood sugar management. How to cope with somatic triggers. So this is thinking about something like interoceptive exposure. How do we get somebody comfortable with that heart palpitation or that shortness of breath, and how to tell the difference between a physiological emergency versus anxiety. Child life strategies for children and families I absolutely love child life specialists. They're so great, and we should learn everything that we can from them. CBT for chronic pain, CBT for insomnia. As I mentioned with COVID, so many people are reporting insomnia. So being able to know how to treat that using something like CBTI is really important. Adjustment to illness and injury. How to adapt leisure activities. How do we help somebody make their life a little bit more accessible after an acquired injury? Expectation management is a huge one. What is it actually going to look like to return to functioning? This is also where we get a chance to look at some of that internalized ableism that might be present after a medical trauma, and what it means to live a fulfilling and productive life after an event like we've been talking about. Cognitive rehabilitation, how to create schedules, how to put reminders, how to cope with memory changes or cognitive changes. How to support medical advocacy or health literacy. I'm always empowering my patients to bring a notebook to their visits, or pre-write out questions, because people get anxious when they get into the doctor's office and they kind of forget what they wanted to ask. Writing it out, taking some time to do that. Helping with health literacy and where to find information and where to find true information, not kind of relying on WebMD for some things. And then seeking representation across ability, status, and social support. How do we connect people with specialty organizations that are related to the illness or injury or acquired disability that they have? And then finally, making sure that we're reading up. A common perpetuating factor of medical trauma is a lack of understanding of a person's illness, injury, their disability, or their experience with it. And so there's those social constraints. And the less that we know about a topic, the more likely we are to accidentally engage in that kind of constraining or invalidating behavior. So don't rely on your client to educate you about their diagnosis or care. Seek out professional organizations or literature or other people to learn more. But then, of course, validate that with your client and their experience. And coordinating with the care team as much as you possibly can. Or if you can't do that directly, joining listservs or leveraging social media like Twitter or Instagram to kind of get connected with experts. I've also included a bunch of resources for more information on particular events and general information that might be of interest to you all. And I will stop there, see if anybody has any questions.
All right, thank you, Dr. McBain. So if you do have a question, feel free to type those in, and I'll advance to the CE slide here in just a bit, but I'll have this slide up here for you all to kind of jot down some resources. So one question kind of came in earlier, I think, when we were talking about the ICUs and just the issue about sleep schedules in hospitals, like kind of what's being talked about, or are we being more aware that, you know, people need sleep and all kind of balancing their medical needs? Any kind of thoughts on that?
Yeah. It's so true that like sometimes within that environment, there's a couple of things. If I really think that lack of sleep is really getting in the way for somebody, or it's kind of leading to emotional distress, there's something that we can do, oftentimes called batched care. So rather than like a nurse coming in at 2 a.m. for a med check, you know, for meds and blood pressure check, and then coming in again at 4, we can batch that care. So we're trying to make as many things happen at the same time as possible, so for less disruptions. So that's a practical thing that we can do. I think that we also that expectation management comes into play of like, you've been in this environment for a couple of days or a week or a couple of weeks, and your sleep has really been disrupted. And so when you get home, being a little bit more structured than you were in the past about setting a consistent bedtime, setting a consistent wake time 7 days a week is going to be really important about getting your life back on schedule. Making sure that people are getting natural daylight when they're in the hospital. Oftentimes people will have their blinds down, and making sure that that's as open as possible during the day to get sunlight and light in, so that the brain is kind of staying on that circadian rhythm of sleep as much as we possibly can.
Thanks. I've got the CE slide up for folks. So again, just jot the code down. Today's code is 3103. And after we're done here at the webinar, I'll send an email out. And if you're interested in a CEU, just be sure to enter that code in, so it'll be given. So I'll leave this up here for a bit. Okay, and then the code again is 3103. Okay, and okay, so somebody has asked. I'm trying to scroll through here. Ready to go. I just had it. Oh, what series do you incorporate with your clients? What are some of the things that you do, Dr. McBain?
Yeah, so I use a lot of the rehab principles and health psych principles that I talked about. I think that, you know, this is hard because we're thinking, you know, it's like so general. So it partly depends on who I'm working with and what they're presenting medical event is. But I do find that a big part of it is behavioral experiments or kind of exposure. Because what can happen is that people, after they experience these types of events, they can really start to feel disempowered. They can feel incompetent, unsure. And so by getting somebody to kind of get back out into the world and practice and try some of these adapted strategies in their life can really help them feel better and build motivation. I think that I often use a lot of cognitive therapy too, about kind of challenging, you know, like beliefs, trauma-related beliefs that are coming up around the event, or people's views of what they, you know, their purpose in life is. So there's a lot, I think, you know, getting into some more existential kind of therapy principles sometimes comes up. But really, I think a lot of this can be couched within, if you're thinking about PTSD, is I use a ton of cognitive processing therapy and prolonged exposure. And those seem to work really well for these types of clients. And really the thing that you want to adjust is the psychoeducation and the normalization and pulling in that expectation management.
Thanks. And I know a lot of you have typed in questions, and we probably won't have time to answer them all, but you know, when I send that email, feel free to send them my way, and I can pass them along to Dr. McBain, and we can kind of continue the conversation that way. So the last question I think we want to ask you is, so I'm at the hospital. How do I find a Dr. McBain? Like what person, or is this a thing at hospitals or clinics, or who's the advocate I should be asking about?
Yes, so that is my life mission to have more of me in these types of settings. So, um, more and more primary care, family med settings are including behavior. So the people that you should probably look out for in terms of like role would be the most common thing is going to be the social worker. And so if they aren't available to provide immediate support, they might be the best person to help get you resources. I work with our chaplains a ton. Their skills are obviously, their training is different than ours, but they have some of those supportive skills that can be helpful in that acute phase. And then a lot of hospitals have a psychiatry consultation liaison service. Sometimes they have enough bandwidth to do more supportive therapy. Other times they're really focused more on like acute psychiatric crises and disposition. But it doesn't hurt to ask. And if nothing else, they can help get you connected with resources. And the more that we start asking about these things, maybe we'll kind of get in the minds of our care teams that they need to have these people on our teams and work towards more kind of broad integrated care.
Well, thank you so much. I know our participants can't unmute themselves because we're on a webinar, but lots of positive comments coming in the question feature. So
thank you all for being here, and I am also on Twitter at Sacha McBain PhD if you want to connect with me on social media and talk more there.
All right, and so thank you again. I'm going to leave the CEU slide up for a bit in case folks need that. Again, the code is 3103, and be sure we'll have a webinar next month for you. So hope to see you all there again. Thank you, everyone.
Thank you.